I want to say hello to everyone. I'm Dr. Sanford Jeames. I'm actually serving on the board of directors for the Alamo Breast Cancer Foundation. I'm very excited today because I get an opportunity to talk about genetic research as it relates to cancer research. And we're very honored today to actually be able to have a conversation with Dr. Sukh Makhnoon of UT Southwestern here in Texas. I'm actually in Austin, Texas, and Dr. Makhnoon is actually in Dallas, Texas. I want to welcome Dr. Makhnoon today and give you an opportunity. Can you tell us a little bit about where you come from and what's your background and how you got interested in genetic research?
Yes, well, thank you, Dr. James, for the invitation. My name is Sukh Makhnoon, as Dr. James mentioned. I am currently an assistant professor at UT Southwestern Medical Center with a secondary appointment at the Simmons Comprehensive Cancer Center. And I'm a genetic epidemiologist and a public health geneticist by training. And most of my research focuses on how to translate genomic applications into routine clinical care. So my background is in, as I mentioned, first a genetic epidemiology degree, and there was also a public health genetics degree, both of which happened at the University of Washington in Seattle. And after that, I moved to do my postdoctoral training at MD Anderson Cancer Center in Houston, Texas. So this is truly a Texas experience here today. And then I moved up to Dallas to do my, to start my independent career as an assistant professor. I'm especially interested in uncertainty related to genetic testing, genetic variant reclassification, which is something that can happen when genetic test results change from one form to another, and how patients experience genomic testing.
Dr. Makhnoon, I'm very excited to hear you talk about your background in public health. I'm a patient advocate and I facilitate cancer support groups here in the Austin area. One of the things that I continue to hear a lot is how can we actually connect the work we do as researchers to the public? So my question to you is, have you considered or do you collaborate with any community-based organizations? Do you work with patient advocates? And if so, in what capacity?
That's a wonderful question. So I think the efforts are underway to get involved with community-based organizations to do a lot of the research that I'm moving into doing right now. So here at UT Southwestern, we have an office called the Community Outreach and Engagement Office, COE, and they are a wonderful resource in terms of facilitating connection between researchers like myself with community organizations who are interested in the type of research that I would like to do. So as a part of that work, I'm being connected with a community organization called Los Barrios, and they are a Hispanics majority serving primary care clinic. And so we are exploring a number of very interesting research in that respect. And I also work with patient advocates. And one of the patient advocates that is actually advising me on how to do research and how to do more patient-oriented research is Carol Bass, who I was connected to through my cancer center director. So I think the answer to the question about whether or not I do research involving patient advocates and community organizations is I think I'm beginning to. And I would like to get more into it as I gain more experience. I've been an assistant professor for 2 months, so, it takes a little time.
I think it never matters how long it takes you to get somewhere is what you do once you get there. And hearing what you say about your work with patient advocates, especially around the questions you mentioned, I'm really curious to know, based on your research, do you believe there is a strong correlation between genetic testing and cancer prevention? What are your thoughts on that?
We recently studied this, looking at how patients, or even individuals, not even patients, all across the United States think about the words cancer prevention and a very related concept called early detection of cancer. So I think, yes, absolutely, cancer prevention can happen through genetic testing, but I think exactly how it happens is tricky, because cancer prevention almost suggests an absolute nature to the phrase, But in cancer, there is nothing that's absolute. So perhaps we can prevent cancer with an absolute degree of certainty if we do in vitro fertilization with pre-implantation genetic diagnosis. But otherwise, any other cancer prevention only reduces your chances of getting cancer to a certain degree. It does not eliminate the chance of getting cancer altogether. So even if you get, say, a mastectomy in response to being a carrier of BRCA1 or BRCA2 variant, there is still some residual level of cancer risk that remains when you have inadvertently missed breast tissue. So even if you leave 1 or 2 cells out in a surgery, there is still a 1 to 2% level of cancer risk. But lowering the cancer risk from 85%, which is what you would have if you did not have a mastectomy, to 1 to 2%, I think is amazing progress. So cancer prevention, I think, is absolutely can happen through genetic testing.
I was really glad to hear you talk about the BRCA gene. As you know, many years ago, there became a lot of conversations around the BRCA gene and its correlation to breast cancer and ovarian cancer. People call it the Angelina Jolie effect. And I'm curious to know, even with that, do you believe that genetic testing creates more alarms for people? And I say that question for this reason. How can we help educate our communities more about how genetic testing can help as opposed to creating alarms and anxiety?
It's a very relevant question and something that we grapple with and work with every day. Well, first, I'll begin with the first part of your question about the Angelina Jolie effect. I think that is wonderful. I think it's wonderful that somebody as popular as her normalized genetic testing and even mastectomy for patients. If you see a role model that you look up to undergo the same experience that you might have to undergo, I think it normalizes that behavior, which is wonderful. On the other hand, a slight caveat there that maybe BRCA1 and BRCA2 genetic testing and the concepts have become so routine that people think that any genetic testing for BRCA1 and 2 is just as effective as clinical genetic testing for BRCA1 and 2. So I mentioned this because the company, 23andMe, which is very popular, also offers BRCA1 and 2 genetic testing. But the testing there is not the same as a testing that one could get at your doctor's office. So those two things are very different. So I wouldn't want anyone to think that because Angelina Jolie had a BRCA1 and 2 testing and I got one at 23andMe, and therefore it's the same thing. It's not. So we should just be a little careful about that. And another part to that story, I think, is patients' reactions to specific types of genetic testing. So once you get a genetic testing done, you can, I think, in broad strokes, have 3 different types of genetic test results. So one is a positive test result, one is a negative test result. And I think those 2 are rather straightforward to understand, although comes with their own unique psychosocial implications. So for example, somebody who tests positive for a mutation that increases their predisposition to breast cancer are often known to feel guilty because they may have passed down that variant to their children inadvertently when they didn't mean to. On the converse side, people who test negative often report feelings of guilt almost, that I am negative. I tested negative for that variant when my sister tested positive for that variant, when we both had an equal chance of inheriting that. So there's often some feeling of guilt. The more trickier one is right in the middle. So tests that are neither positive nor negative, but right in the middle, something we'll call an uncertain genetic test result. So these are genetic test results that for some reason or another, we don't have enough information on. So we cannot say for sure whether or not it increases your chance for cancer. I think as a patient myself, getting an answer that says, oh, we don't know if your test was negative or positive is kind of alarming. But there's also evidence to show that the genetic counselors these days, who are the people who are tasked with explaining your genetic test result to them, do such a wonderful job with explaining the different types of genetic test results that the negative psychosocial outcomes following genetic testing are very limited. So I wouldn't worry about not understanding or having to live with a genetic test result as something that stops us from getting genetic testing.
I'm really interested to hear you talk a little bit more about genetic testing as it relates to persons of color. As it relates to breast cancer, we know that Black women have higher mortality rates from breast cancer, although triple negative breast cancer may be more prevalent in whites. As it relates to genetic testing and counseling, I'm curious to know how we can use the research that you do to help educate women of color about breast cancer and its correlation to genetic testing as well as counseling. What are your thoughts on that?
So in general, the risk of carrying a pathogenic variant in a gene that increases our predisposition to cancer is actually the same regardless of our race and ethnicity. So it's the same across the board, with perhaps a slight blip if you are an Ashkenazi Jewish ancestry, if you have an Ashkenazi Jewish ancestry, but otherwise it's the same all throughout. I think the disparities in access to genetic testing and outcomes following genetic testing happen because of other reasons. So it's that our genetics is different, but that we don't have the same access to genetic testing as we should. So for all patients across the board, around 5 to 10% of breast cancer is caused by mutations that increase your chances of breast cancer. So for all types of women, regardless of your race or your ethnicity, a very small proportion of them are likely to benefit from genetic testing. But there is a lot of data that shows that certain women, especially Black women and Latino women, are not referred to genetic testing as they should. And there are other data to show that they don't uptake genetic testing as often that they should. And these have underlying reasons related to cost. Even though the cost of genetic testing has gone down, the cost of genetic counseling is still quite high. So that can prohibit access to genetic testing. So I think for all women, regardless of race and ethnicity, genetic testing can be helpful. It's just getting to the genetic testing.
Thank you for saying that. I'm really curious to know, with the work that you do, how much discussions around genetic testing and counseling, how much discussion do you have with the oncologists and breast cancer surgeons there at the Simmons Cancer Center to help them understand more about the work that you do?
It's a great question, and I think comes down to being part of ivory towers, what most of my research is done. So I think at centers such as ourselves, where we see a lot of patients and we have healthcare providers with the training and resources needed to provide genetic counseling to women, genetic referrals and testing happens largely as it should. So by that, I mean, if there is an oncologist here at our Simmons Comprehensive Cancer Center, they have the access to a team of wonderful genetic counselors who can follow through on the risk assessment, on the genetic counseling, the genetic testing, the return of genetic test results, and following management of care. For a community oncologist, on the other hand, I think the struggles are much higher, much higher, right? So they don't have access to the same amount of genetic counseling services as someone at our medical center might have. So I think the goal right now is how to get genetic services to those who need most. We know that most of cancer patients get their care at community cancer centers and not at comprehensive cancer centers like where I work. So for our oncologists, it's an easier task than for community oncologists.
Curious, I wanted you to elaborate a little bit about your interests. How did you become interested in genetical research, and how did you become interested specifically around cancer?
Yes, no, not at all. These are great questions to ask. When I was an undergrad in Bangladesh, that's when the Human Genome Project was being done. So for those of us who are not involved in this every day like I am, the Human Genome Project was the idea to sequence the entire human genome from A to Z. And this was being celebrated when I was finishing my undergrad in Bangladesh. Although I will add the caveat that we had not actually finished sequencing the entire human genome, but we celebrated a little early, but that's okay. So at that time, I was presenting in a class presentation, the silly ones that undergrads have to do about the Human Genome Project. And I think after all of my explanations, someone in the class had asked, so what's the point of all of this? What are we going to do with it? And I had no answer. So I did not know what the point of sequencing the entire human genome was. And I thought it's worth finding out. So which is why I got my master's degree in genetic epidemiology, which is where we look at the entire human genome to try to find the abnormalities that matter for human health. And at that time, I worked in something called a metabolic syndrome, but I no longer work in it. And then I think since 2014, I've started working in cancer genetics. And for the past, it's got 8 years now, I've worked in 3 cancer centers looking at breast, ovarian, and colorectal cancer.
I was glad to hear you talk about your background a little bit, particularly around the sequencing of the human genome, because it leads to my next question for you. As we continue to obtain so much more information about individual persons, I'm still curious to know, in your words, what do we do with the information? And I'm really curious to know the work that you do. How can we convey this information in a way that's helpful to populations that are more impacted by cancer and mortality rates? How can we do that, in your opinion?
So as we learn more about human genetic variation, I think that helps us understand their contributions to disease. So not all diseases are genetic, definitely not. So for example, if you get malaria, that's probably more due to the mosquito than because of your genes, although there is some genetic contribution to that also. And then there are other diseases that are predominantly genetic. So for those diseases, I think it's very important to understand which human beings are more likely to get disease. And then that way we can target our interventions to them specifically to make sure we have the most impact for the healthcare dollars that we're spending. So that is the reason that we should be studying all humans everywhere and looking at their susceptibility to disease. But we don't. And in genetics, we have a big problem of diversity. So we don't study all populations equally well. And people of European ancestry are most represented in all the data sets we have. And African Americans and Asian Americans are moderately represented. Indigenous populations are notably absent, I would say, from all the databases that we have. And as a result, we have certain mutations that seem more prevalent in racial and ethnic minorities. The uncertain variant that I was mentioning earlier is of particular interest to me, is more prevalent in racial and ethnic minorities. And that's an access problem. That is not a biological difference. It's not that those populations have more of those variants. It's just that we haven't tested enough of them to know what normal human genetic variation looks like in those populations. So we flag more of the mutations in those populations as problematic when in fact they're not. So I think by understanding more of the genetic variation, we can design interventions that can affect them. And as patients, I think what I would like them to understand is when you receive clinical care, there is some type of variance that will be more prevalent in you, but I think genetic counseling and our providers these days do a fairly great job in explaining those to us. So I wouldn't be afraid of that. But also when it comes to participation in genetic research, it would be wonderful to have a more representative population in our study samples, I think, which is more of a responsibility on my part than on the patient's part. But yes.
Dr. Makhnoon, I started my cancer career, if you could say, or cancer journey, as an advocate, primarily focusing on prostate cancer in African-American men here in the United States, of course, particularly in the South where I used to live at. And now, of course, I'm also a breast cancer advocate, and I work with populations who have other solid tumors. I'm curious to know, do you have a specialty in your cancer area? And if so, what is it? And at the same time, for genetic research, is it even prevalent to have a specific area of cancer that you do in genetic research, as opposed to what you said before, that it's genetic research and all populations are impacted by it? So I'm curious to know, do you have a specific area of cancer that you specialize in? What is it? And if so, how did you get involved in that?
So, yes, so diseases vary by their genetic contribution, but even within cancer, there are differences in how much of a genetic contribution different cancers have. So, for example, breast and ovarian cancers are perhaps the poster children when it comes to cancer genetics, because we know so much about them, because BRCA1 and 2 were discovered, were one of the first genes to be discovered that increased predisposition to cancer. So we have a lot of research on them. So breast and ovarian cancer for that reason. And the other one is colorectal cancer, which is also another disease where we have a lot of information with regards to genetic contribution to disease. So there's something called Lynch syndrome that increases your chances of cancer to up to 90% in some cases. So from the population level of 1 to 2% to 90% is quite the increase in risk. So for that reason, a lot of my research is focused on breast, ovarian, and colorectal cancers. But other cancers can also be genetic, and a lot of people study them, and I think are very important. One of the reasons I study breast, ovarian, and colorectal cancer is because the specific type of genetic test results I'm interested in are a rare occurrence. So if you increase your sample size to begin with, you have a higher chance of finding those types of genetic test results to study them, as opposed to studying a rare thing within another rare thing.
I'm really interested to hear you talk a little bit more about what you just said, to having more samples. I'm really curious to know, and it leads to the other thing you mentioned about studying, everyone. You mentioned earlier that there are significant gaps and disparities as it relates to certain populations, not just in the United States, but in the world. So I'm curious to know your perspective. Do you feel that every person should have a genetical sequencing to understand their genetics? And if so, how does that lead again to lesser cancer mortality rates in some ways? Because that is the significant issue that I encounter, and that the populations or persons and groups that I interact with have higher incidences of certain cancers, higher mortality rates, but yet there's less access to do something about it. So how can we use this genetic research to impact the disparities gap that are continuing to exist in our country and throughout the world, in your opinion?
It's such a complicated question that I'm trying to wrap my head around it. I don't think necessarily genetic testing is going to narrow the gap in cancer disparities. That is not going to happen. I think, in fact, it may have been the other way, that by introducing yet another type of innovation in medicine, we are widening the gap in disparities. We are making the disparities worse. That is not to say that this is not helpful and one should not do it. I think our efforts are currently focused on how do we get the genetic testing to those who need it. And I think the operational word here is those who need it. Not everybody needs genetic testing. And I don't think the evidence is there yet to suggest that everybody should get genetic testing, right? So there are some wild ideas that are being proposed. One of them, I think every great idea begins with a wild idea, so this is good, is that why not sequence every newborn in the United States? That way, all of our DNA will be ready at hand for whenever we need it. I think the evidence currently says that we are likely to cause more harm than good by doing that. So I think for a person who is at average risk, average meaning you don't have a higher genetic risk compared to the general population, the reasons for which you might get genetic testing needs to be really convincing. And I don't think the data is there yet. But for people who are at a higher genetic risk, which would be a lot of people who already have cancer and a lot of people who have a family history of cancer, right? So how many relatives have cancer? What are your relationships to them? And when did they get cancer? Was their age of onset below 50 years? So all of those are information that can tell us whether or not you're at high risk of cancer. For those people, there is a lot of evidence, a lot of convincing evidence that says that they should get genetic testing. So I think the answer to the question about whether should everybody get it? No, not yet. I think the people who need it should get it. So it's the idea of precision medicine, that we get the right test to the right people at the right time is what we are striving towards.
Thank you very much. You actually answered the question in a way that I was considering as well, particularly when you discuss the idea of newborns. And I want to appreciate taking time to talk to me today about the research that you're doing, and we're almost finished here. I do have just a couple more things I wanted to ask you, and this is related to the future of what you do. So you are at Simmons Cancer Center, and can you talk a little bit about how your research is going to help improve cancer discussions? Because I love the word you talked about. I believe you used the word innovation. And I'm curious to know, because as old as the human genome has been studied, it is still very much in its infancy. So I'd like you to talk a little bit about how you envision the work you do and how it can impact the cancer discussions, particularly around, I go back to what I said earlier, around the cancer prevention or intervention strategies.
Yes. So I think a lot of people work in a lot of different areas within this cancer spectrum. So it comes all the way up from prevention all the way down to cancer treatment. And in all of these areas, there can be applications related to genetics. So for cancer prevention, I already mentioned the one about mastectomies, but we can also do oophorectomies to prevent ovarian cancer. We can also do more regular monitoring through, let's say, mammographies or breast MRIs to detect cancer early. So we find them at a stage when they are more amenable to treatment, all the way to the other end of the spectrum when there is treatment. So for people whose tumors have BRCA1 and 2 mutations, are more responsive to PARP inhibitors. So treatment can be guided based on your genetic test results. My area of focus in all of this comes in how to translate those innovations into patient care. So something that I'm very interested in personally, and I'm working on it actively right now, is something called variant reclassification. So when we get a genetic test result, it's not set in stone. Over time, as we gather more information about that genetic variant, as we learn more about human genetic variation in general, we can say that, oh, this variant that yesterday we called a variant of uncertain significance is now actually a benign variant, a variant that you don't have to worry about. And this change in reclassification, so it changes from one classification to another, that's called a reclassification, can take years, or it can take months. So what I'm working on right now is how do we tell patients that yesterday the genetic test result that was this is now changing to something else. Also, how do you proactively cue patients to say that, just so you know, this might change in future and we might change your medical care because of it down the line. So a lot of the work is focused on what patients think, how patients would like to be informed about their change in genetic test results, and how providers think they should be informed about their genetic test result. So changes that impact medical care, of course, I think we would agree, need a more in-person touch. So you would probably want the patient to come back to the clinic or have a video teleconference about a change that impacts their care, versus a change in genetic variant classification that does not impact care. Probably could use a lower amount of touch. But I think there is currently some discordance between how patients think about it and how providers think about it. So we're trying to get into a consensus. So everybody, all the stakeholders in the group would be okay and come to a good solution about how they would like their care delivered. So I think the innovation transfer to patient care is what I work on.
Dr. Makhnoon, I want to thank you for taking the time to talk to me today about the work that you do. I really commend you on this work, and I would hope that you would be very forward-thinking in pushing this conversation into clinical practice. As a patient advocate, I truly feel like patient education is a key because patients do want to know what you're doing and they want to know why you're doing it and how it will help them. I want to thank you again for taking time. I look forward to meeting you soon. I hope that you may take time to visit the symposium in December in San Antonio. If not, I will, I guess, see you on the freeway the next time I come to the Dallas area. So thank you very much. Thank you.